Okay, so welcome everybody. Thanks for coming to today's Lunch and Learn. Um, so today, essentially, we're going to review some of the updates to our standing CT protocols, including some minor revisions to existing protocols, as well as go over a couple of recently introduced new protocols. Then I just want to get into a little bit of a discussion around some of the nuances of some of our standing protocols and where we've seen a little bit of variation or divergence in terms of how the different sites are doing things, just so that we can ensure that protocols are being performed uniformly across the platform. And then finally, Dr. Chan will go over some details regarding dual energy CT, including some of the specific scenarios in which we're meant to be including these algorithms and why we're doing them and the benefits of this additional these additional sequences. So to start off, for the sake of simplicity, we've decided to remove some of our protocols that were a bit redundant or being used incorrectly. So this includes the biphasic liver CT. Um, Unfortunately, as it presently stands, this protocol is still available for RADs to select. So although they will be reminded that this protocol is no longer actionable going forward, until we're able to entirely remove the protocol from Epic, you may still rarely encounter it being selected. For the most part, you shouldn't encounter it very often. It's actually one of the reasons that we're removing the protocol is it's really just not being used all that often. And when it is being used, it's usually being used incorrectly. So in those cases where you do still see the biphasic liver protocol until it's removed, these should be defaulted to the triphasic liver protocol, which is otherwise intended for workup of indeterminate liver lesions. Otherwise, we've also elected to remove the post-RFA specific renal protocol. Similar to the biphasic liver, the protocol still at this point remains in Epic, and can be selected by the RADS as a protocol, but should default to the renal mass triphasic protocol. And we will be removing these shortly from Epic so that they aren't able to be selected anymore. Aside from that, a couple of other minor revisions to our existing protocols. One of the more important changes made recently is that to the post-RFA and TACE liver CT, which previously was a triphasic CT, now is quadriphasic, so includes a delayed phase of the abdomen in addition to the existing non-contrast arterial and venous phases. This is essentially at the request of some of our IRs that commonly read these studies, um, primarily because these are mostly done in cases of HCC, and that delayed phase imaging quite substantially increases our sensitivity for looking for washout of recurrent lesions, and is quite useful in improving our accuracy. So that's the main reason for including these additional delayed phase. Another minor change to our existing protocol includes the addition of some 3D bone reconstructions to all head, facial bone, and CT chest examinations, specifically done in the context of trauma. So for the chest exam, this will be added to the CT CAP trauma exam that we currently have as a standalone protocol. For heads and facial bone, a trauma-specific CT head or CT head and facial bone protocol will be constructed on the scanners to be used in cases of trauma, so that they include these 3D bone reconstructions by default. So here's just a couple of examples of those 3D recons. This was actually a case that I had on call yesterday evening with the 3D facial bone reconstruction. Just gives us a little bit of ease of detecting some subtle fractures, and just a little bit easier to interpret when we have these 3D recons. Occasionally, subtle non-displaced fractures can be difficult to appreciate, and can be easily missed when you're scrolling through quickly on the axial or whatever plane that you're in, particularly if that non-displaced fracture is in the plane of acquisition or in the plane that you're reading. Here on the right, you see the chest bone reconstruction, and primarily for sternal injuries and rib injuries. For ribs, often challenging, particularly when there's multiple rib fractures, to um, specifically locate where the fracture is. Often need to count the ribs, and is a little bit more challenging to do so on that axial when you're scrolling up and down. Whereas when you have this nice 3D reconstruction, very quickly can see a rib fracture and determine where within the rib, what rib it is, and how many there are. So um, quite useful from that regard. Um, Additionally, like I said, I wanted just to address some of the minor cross-site variability that we've seen in our standing protocols and make sure that we're just all on the same page with regards to how the protocols are written out, and try to achieve that uniformity. Um, Specifically for CT enterography, when the exam is being performed for investigation of a bowel mass or for investigation of anemia, NYD, the enterography ideally should be performed as a multiphasic exam, including both non-contrast arterial and venous phase. The main reason, or really only reason, that we should be performing the single phase venous timed enterography is for investigation, either baseline or follow-up imaging of inflammatory bowel disease, such as Crohn's disease. Those patients are frequent flyers in terms of imaging. They get, repeat CTs throughout their lifetime. So wherever we can save the radiation dose for those frequent flyers, it's ideal. So those are the main reasons that we do those exams as a single phase study, and really doesn't add a ton more information doing the multi-phase. But when it comes to evaluating for anemia, so looking for extrav or looking for masses, bowel masses, having those multiphasic images is quite useful in terms of increasing our sensitivity and accuracy. So please ensure that if it is for those indications that we're doing the multiphasic exam. Another exam where there's a little bit of variability, not as often, um, but occasionally is missed, is with regards to the high resolution lung CT, specifically for cases where patients have already undergone baseline high resolution CT imaging at THP, generally for investigation of interstitial lung disease. Um, and the exam that we're currently doing is being done just as a follow-up study. Those follow-up exams do not routinely require the prone or expiratory images that we do at baseline imaging. Um, Really, the follow-up exam can be performed with only supine and inspiratory imaging, unless it's specifically indicated otherwise somewhere in the order or protocol, which generally it's not. So those follow-up exams really don't need those additional prone or expiratory images. The supine alone is sufficient. With regards to CT appendicitis, really I've just removed the age and BMI base determinants for use of oral contrast in this protocol from our protocol document. I don't think we were really doing it very often already. So just to keep it consistent and make sure that what we're doing aligns with the document, I've removed those determinations. So essentially, all these exams for appendicitis, like with the diverticulitis, can be done without oral contrast, regardless of patient age and BMI. I think probably in the near term, we'll revisit oral contrast use as a whole in the ED population, and may potentially expand those indications where we are not using oral contrast. Um, but that requires a little bit further discussion. So we'll revisit that, and we'll keep you apprised of any additional changes in that regard. For ischemic bowel, uh, I've heard that there may be a little bit of differences in terms of what's routinely done with regards to oral contrast. So the way that the protocol is written is generally we should be trying to give negative oral contrast in these patients, 900 milliliters of water, if tolerated. Obviously, a lot of these patients are relatively unwell, probably a good amount of them are not going to be able to tolerate. In that case, then obviously we would proceed without. But if they are able to tolerate, ideally, this exam is done with water on board. And then one other area that I think um, hopefully we can achieve some increased quality as a whole if we start applying this on a consistent basis is with regards to metal artifact. So in the case of metal prostheses or any metal hardware within this scanned field of view, we should be routinely applying the Siemens IMAR, which is a metal artifact reduction algorithm, and allows us to get improved imaging through that area where we would otherwise have quite substantial streak artifact. So this is really critically important, particularly in cases of lower extremity or upper extremity imaging where there's a prosthesis and there's a question of either periprosthetic fracture or some other periprosthetic complication, as well as within the pelvis when there's hip prostheses, which really quite substantially degrades and limits assessment of the pelvic viscera through that level. Aside from that, I've also asked that where we're able to apply this, because not all scanners are capable of doing this, but where we are at least presently capable of doing it, we're going to build out some metal specific protocols for the extremities in use where there is metallic hardware, where it employs a tin filter with a higher KVP of 150 KVP, and allows us to get even better improved quality of imaging in the setting of metal. So we'll start applying that as well, and then that can also have the IMAR algorithm applied to it after the fact. So in terms of some of the new protocols that we've introduced as of late, the first you may have already encountered, which is that low dose whole body myeloma screen. And this is really meant to replace the radiographic skeletal surveys for the assessment of myeloma or MGUS. And really offers quite substantially better sensitivity compared to the routine skeletal surveys that we've been doing up till this point. So this is generally an on-contrast examination, covers nearly the entire body, pretty much from vertex of the cranial vault all the way through the upper calves just below the knees. For this exam, patient positioning is really of utmost importance to ensure that we get good quality imaging. For this exam, the patient is positioned on the table supine with arms down, hands towards the front of their body with the palms together, essentially like they're praying, but with arms straightened and fingers directed down towards their feet. This allows the patient to bring their arms anteriorly to the anterior part of the chest, away from the side, and thus reduces streak artifact through the spine. However, because in that case the arms are now forward over the anterior chest, there is some increased beam hardening artifact through the sternum. So if there is a specific clinical question from the referring physician concerning the sternum, then we should be routinely repeating dedicated acquisition, covering the sternum with the arms down either at their side or if they can tolerate, ideally with the arms up over the head. But just a small field of view covering the sternum in those cases. So here's an example from the literature essentially showing that appropriate positioning with the arms down, relatively straightened with the hands in front of the body, generally going to be in front of the pelvis, palms together. And you can see here from the axials, it brings the arms forward over the anterior aspect of the chest as opposed to where they would routinely be posteriorly. And any streak artifact is more through that anterior portion of the chest and away from the spine and allows us to get a good look at the spine. Another exam that we've recently introduced and we've started to get some orders for and started to perform recently is the 4D parathyroid neck. Really fancy nomenclature, but the exam itself is fairly basic. It's 4D just means that there's a temporal element to it. So this is really just a multi-phase exam of the neck, performed to increase the sensitivity and specificity and detection and characterization of parathyroid lesions. So for coverage and parameters, really it's the same as our routine soft tissue neck examination. Main difference being that we're requiring multiple phases, including a non-contrast, an arterial, and a venous phase contrast exam. Um, as opposed to really the routine venous phase that we're requiring for a routine neck. But otherwise, the parameters for those unenhanced arterial and venous phase are all the same, and we're getting it in the triplanar, axial, coronal, and sagittals all sent to PACS for each one of those sequences. So here's an example case that I was able to grab from Sunnybrook that was uploaded to our system, where they've actually been doing this exam for a number of years now. And that's kind of what prompted the ENTs to request that we start doing these, just because it started to expand across the GTA, and there's more sites now offering this 4D examination. And here you can see, in this case, there's this lobulated soft tissue at the inferior aspect of the thyroid lobe. Um, in this case, maybe there's a thin cleft that separates the two, but it looks like you lose it in some areas. So, question of maybe this could be an exophytic thyroid lesion rather than a parathyroid lesion. Um, but here, on this early phase, this arterial phase image, the attenuation is fairly similar. But when you get to the venous phase images, the attenuation of the thyroid, and this lesion becomes more starkly different. You get washout of the parathyroid lesion, in this case, a parathyroid adenoma, which is fairly typical to see, where you'll have either hyper attenuation of the parathyroid relative to the thyroid with subsequent washout, or isoattenuation, as in this case, with that washout. Even the non-contrast images, you typically do get some difference in the attenuation of these, and allows us to improve our diagnostic accuracy, allows us to differentiate these lesions from either exophytic thyroid lesions or lymph nodes. So just to wrap up my part, before I hand over to Mike, I just wanted to spend a bit of time talking about CT urograms. So going forward, one of the things that we're going to request is that the adequacy of the urographic phase images from this exam be checked prior to the patient getting off the table. And if you feel that the images are inadequate, that we repeat an additional urographic phase image 2 minutes later, with the patient placed into the prone position, instead of the supine, for the initial urographic phase images. So, what do I mean when I'm referring to the adequacy of the urographic phase? Generally we want good opacification of the upper renal collecting system on those urographic phase images. So that's the renal calyces, the renal pelvis, and the ureters, all the way down to the bladder. Ideally, we'd have the bladder also completely opacified on the urographic phase images, but given that we acquire our urographic phase images relatively early compared to other protocols that exist in the literature, this is often not going to be the case, and I really wouldn't routinely repeat urographic phase images just for incomplete opacification of the bladder. We're going to see that in most cases, so I wouldn't repeat just for that. But for the remainder of the upper renal collecting system, ideally we want to have that pretty well opacified. So generally what's going to cause the urographic phase images to be suboptimal is when there's some type of downstream obstruction of the renal collecting system, which is going to result in hydronephrosis. It's going to result in impaired contrast excretion. And just by virtue of having the renal collecting system distended, the excreted contrast is not going to completely opacified that distended renal collecting system. It's usually just going to layer dependently within the renal pelvis and calyces, as well as that dilated ureter. But really the obstruction is the primary reason that we're doing the exam. It's the primary thing that we're looking to characterize with these urographic phase images. So as best we can, we should be attempting to try to get contrast down to that level of obstruction. Additionally, by placing the patient in prone position, even if we're not able to get contrast all the way down to the obstruction, it does allow the excreted contrast to fall into the antidependent portions of the dilated renal collecting system. So between that and the supine images that we took before, taken together, we're able to get a good look at the contour of the urothelium throughout the dilated system. What I would say as a general guiding principle, we'll go over a couple of cases, but in general, I would say err towards acquiring additional prone images if you feel that there's any question of uh, inadequacy of those urographic phase images. If after you obtain the repeat prone images, there's still really poor opacification of the distal renal collecting system, so mid to distal ureter is still completely non-opacified, um, by all means, you feel free to contact the consult rad for additional direction on whether or not further imaging is necessary. Most of the time, I would say it's probably going to be fine to just call it at that point, because in cases of really severe obstruction, it may take substantially longer really to get contrast down there. So, it's not necessarily worthwhile to keep the patient for 30 minutes, but um, as best we can, getting that initial prone image after 2 minutes will give us quite a bit more information over what we're doing now. So with all that said, let's go over a couple of examples just to illustrate what is considered generally passable and what I would say would warrant repeat prone imaging. So to start off, this is an example of a well-opacified renal collecting system. Excreted contrast completely opacifies and fills the renal pelvis and calyces on both sides. You can see very nicely opacified, and the ureters as well are well opacified, coming down all the way to the bladder. Sorry, a little bit laggy with this recording, but you can see these ureters can be followed all the way down and are nicely opacified throughout. Here, just a couple of still images. On the right, you can see this cystic fullness anterior to the kidney, looks to be probably a big dilated renal pelvis, and the dilated calyces and the intrapolar kidney. Subsequent urographic phase images, you get complete opacification of the calyces here, but this renal pelvis is incompletely opacified with that hyperdense contrast layering posteriorly, but the antidependent portion completely non-opacified. And if you were to scroll further down, most of the ureter was non-opacified, but there was some layering contrast dependently in the at least proximal and mid portions of the ureter. So this is the type of case where ideally we wait a little bit longer and then repeat imaging with patient in prone to allow that contrast to dump anteriorly and get a nice visualization of the contour of the urothelium in the anterior portion of that dilated renal collecting system. Here, another case of, in this case, bilateral hydronephrosis and hydroureter, where the contrast appears to mostly layer dependently within these dilated renal calyces and pelvis, and really not much contrast getting into the ureters, a little bit on the right into the proximal ureter, but really beyond the proximal ureter, there's nothing in this dilated ureter here on the right and then here on the left, and all the way down, really nothing going all the way down. So in this case, you can see this big dilated distended urinary bladder, lobulated contour related to all these little diverticula. So this is chronic urinary retention, and that's probably what's causing this upstream hydronephrosis as well. So in a case like this, quite severe, we may even after the 2 minutes not get a lot of contrast down to the distal portions of the ureter, but that I don't think necessarily is going to necessitate an additional longer wait. But by all means, just contact the consult rad and ask them if they think it warrants additional imaging or if you can call it at that point. Here, another case. Um, where you're getting, oh no, sorry, this is the same one here. So here, the left renal collecting system appears dilated, incomplete opacification getting into the distal ureter, um, and even the renal pelvis is almost completely opacified, maybe a little bit of incomplete opacification, but for the most part, it's the ureter here where as you get down into the distal ureter, you start to lose it. So here it's still kind of opacified, but then getting into the distal portion of the ureter within the renal pelvis, it's really non-opacified. So here is the exact type of case where a couple more minutes, patient in prone position gets us a little bit of a better chance of making sure that we opacify that distal segment. What you will notice that uh, on this case, there is, as you come down on the right as well, um, this segment of non-opacified mid-ureter, but then the distal ureter does appear normally opacified beyond that. This is fairly commonly seen. It's likely related to normal peristalsis of the ureter. So it's not uncommon to have these short segments of non-dilated, or sorry, non-opacified ureter. The main difference is that the renal collecting system is not dilated. You're not getting layering contrast. It's just that you have these segments where the ureter has spasm or has peristalsed, and you're just not getting opacification through that segment. But often you'll see contrast beyond that level, and really the ureter is not dilated, the renal collecting system is not dilated. There's no layering of contrast. So that alone is not a reason to repeat, but in this case, we have that dilated ureter with that layering contrast. That's a good reason to repeat with the prone. And then here, there's another case where there's um, just another example of multiple segments of non-opacification here in the left ureter, primarily uh, from the pelvic inlet and into the bladder. So this is one of the common areas that you'll see the ureter kind of disappear for a short segment, and that's just from some extrinsic compression as the ureter passes over the iliac vessels at the pelvic brim. It's not uncommon to get the ureter a little bit compressed, and you don't really always see it well opacified on the urographic phase images, but here you can see it reappears, but then does again disappear kind of distally all the way to the UVJ. Again, probably related to peristalsis. The ureter above it is not dilated. There's no layering of contrast. This is just normal peristalsis. Would not be a reason to repeat this. And then one last case that I want to highlight, just a little bit of a mimic to be aware of. Here you see some cystic fullness of the left renal sinus, fat, and extending into the hilum. Looks like it may very well be a dilated renal pelvis and dilated calyces. But then we go on to our urographic phase images, and you see that there is incomplete opacification of this cystic area, but as opposed to the layering contrast that you would expect in a dilated renal collecting system in the setting of hydronephrosis, instead what you're getting is this tubular contrast that's surrounded by these non-enhancing fluid density areas. And essentially what this is just numerous parapelvic cysts that are encasing the otherwise well opacified renal collecting system. So this is one thing to look out for, as it can certainly mimic hydronephrosis on a quick look, particularly on the venous phase, uh, and can give the appearance of incomplete opacification of the renal collecting system on the urographic phase. But the difference here is that instead of layering contrast dependently within that fluid area. Instead, we have this normal branching opacified renal collecting system that's surrounded and encased by these non-enhancing or non-opacified parapelvic cysts. So that's pretty much it for my part. Thanks for your attention. I'm going to hand things over to Mike and then maybe we can return at the end if there's any questions, just to go over.
Sounds good. You can see my slides, right?
Yep.
All right. So I just wanted to do like a very quick primer on dual energy CT, just because we've been increasing our use of dual energy over the last year or so. So I just wanted to give you a sense of why I think or we think it's important, um, and not just us wasting your time. So, as many of you already know, traditional CT uses a spectrum of energy to obtain images. And on our traditional CT imaging, different elemental compositions like soft tissue, etc., can be represented by the same CT number or Hounsfield unit. So whether something is made of iodine or calcium, etc., it will still appear hyperdense on CT and may have a similar Hounsfield unit. So that's a limitation. So dual energy CT actually tries to address this limitation by imaging structures at two different energy levels and using some complex math that is beyond me in order to decompose the signal into different constituents like iodine or calcium, etc. So by using this technique, we're able to unlock this powerful ability to discriminate certain elements within the image. Traditionally, dual energy CT images are obtained at 80 and 140, and these can be obtained in a variety of different ways, which I won't go through today. But the protocols that we've been implementing have all really been for ED and inpatients. So as you all know, we've been implementing it on our routine CT heads in order to provide this bone removal sequence. And really, the number one reason to do this is to look for subtle subdural hematomas, which is often a question in our ED inpatient population, patients with falls, etc. But we also there's a typo here, but we also our first application was in post EVT CT heads, where we use virtual non-contrast and iodine maps in order to discriminate between contrast staining and true bleeds post EVT. We've been using it in our abdomens, our routine abdomens, and I want to propose using it in our ischemic bowel cases. Where we'll have virtual non-contrast maps, iodine maps, and monoenergetic maps. And these can help accentuate contrast enhancing structures as well as accentuate things that don't enhance, and also help discriminate between whether a hyperdense structure is due to enhancement or is it due to calcification, etc. And then probably one of my favorite applications is in MSK studies, uh, using our virtual non-calcium maps to create these bone marrow edema images that can really highlight fractures. And because I think this is one of the things that is most easily missed by radiologists. So just some examples. So here's an example in our post-EVT patients. And at the top, you can see um, what we're provided with are our traditional CT images, but on the bottom you have a VNC or virtual non-contrast map, which basically subtracts out all of the iodine containing substances, and then an iodine map where the orange basically highlights all the iodine uh, in the image. And here you can see that we see this hyperdensity in the sulci along the left temporal occipital region. that subtracts out on the VNC and is highlighted on the iodine map. So we know in this patient, this hyperdensity is due to contrast staining, and that they don't have to worry necessarily about hemorrhagic conversion in this patient. Here's an example of our bone removal. Um, in this patient, post-fall, you can see this very subtle subdural hematoma, this hyperdense crescentic thing under the bone. That is much, I would argue, much more difficult to visualize on the traditional CT images. So this is probably the #1 reason to use this bone removal application. In our abdomens, we have, again, our iodine maps with the orange color. Our VNC maps are virtual non-contrast, where all iodine is subtracted out. And then our monoenergetic maps, these I find are very helpful in highlighting enhancing lesions. So if you're looking for any subtle enhancing lesions, for example, in the liver, or if you're looking for subtle contrast extravasation in the bowel, this can be a very helpful sequence. And then, like I said, one of my favorite applications, the bone marrow edema. So traditionally, without dual energy CT, bone marrow edema really could only be appreciated on MRI. But with dual energy, we're able to unlock this ability on our CT images. So for example, in this case where there is a very subtle intertrochanteric fracture, non-displaced, I would argue that it's easy to walk by this little defect in the cortex along the greater trochanter. But when you look at the bone marrow edema maps, you see lots of green here. It's hard to walk by that. So it tells you you need to look at this area closer, and that should direct the radiologist to seeing this intertrochanteric fracture. And then here on the right, you have a T2 FATSAT image on MRI that basically shows you how accurate this bone marrow edema map is. It basically follows the similar distribution. On the bottom, we have a CT of the wrist. And in the scaphoid, you don't really see a clear fracture line. But on the bone marrow edema map, you can see that there's clear edema in this region, which should encourage the radiologist to interrogate this area closer and look for a very subtle occult fracture. Okay, I also wanted to go through some images on PACS. Just let me bring those up. All right, so here's another case of a post-EVT patient. We see that there's this hyperdense lesion or focus in the left lentiform nucleus. And we wonder to ourselves, is this hemorrhagic conversion of the stroke? Clearly we can see a developing left MCA territory stroke here. Or is this contrast staining? So when we look at our virtual non-contrast map, we can see that the majority of this hyperdense focus along the posterior aspect actually subtracts out on our virtual non-contrast, and we can see that it's red or orange on our iodine maps. So we can be pretty confident that most of that part of the back is contrast staining. However, in this case, we also see hyperdensity that persists on the virtual non-contrast map, and we know that there is also an element of hemorrhagic conversion. And when we look at the follow-up imaging on the bottom left here, we see that all the contrast staining component disappears and that hemorrhagic conversion actually sticks around. So in some cases you have this mixture, some cases you have only contrast staining, in some cases you have only hemorrhagic conversion. So the dual energy CT sequences can really help tease that out. This is just another example of how dual energy can help with this discrimination. So another case where we see hyperdensity in the left lentiform nucleus, and we do see a little bit of signal there on our iodine maps, and we see it basically disappear on our virtual non-contrast. So we can say that this is most likely contrast staining in the setting of prior UVT. Here's one of the applications that I haven't talked about, but is available, and you can touch base with Rob and Sheila about how to apply this. Sometimes we might see these hyperdensities in our CT heads, and we wonder, um, is this hemorrhage or is this calcification? So in this case, that question was posed. And because we acquire all of our CT heads in the ED and inpatient setting in dual energy, we should be able to do post-processing to figure this out. In this case, we've created virtual non-calcium and calcium maps um, that you can see at the bottom here. You can see that this thing is yellow-red on the virtual calcium map, and then our virtual non-calcium map, we don't see this hyperdensity. So we can be very confident that this lesion is actually calcification rather than hemorrhage, and don't need an MRI to further characterize. So it'd be really helpful if Rob or and/or Sheila to show the techs how to do this post-processing at the scanner. I know this is not available yet at Q, but will be available once the new scanner is in. So it will apply to across the platform once once the new scanner is in. Here's another example in the abdomen. This is not the greatest example of how it can be applied, but for example, we see lots of incidental lesions in abdominal imaging. Sometimes we might see a hyperdense cyst, and we can wonder to ourselves, is this an RCC that needs follow-up? And in these cases, our virtual non-contrast and iodine maps should help. If you see no signal on the iodine map and you see that it is persistently hyperdense on the virtual non-contrast, you can be fairly certain that it's a hyperdense cyst, versus if you see that it's clearly enhancing between the virtual non-contrast and the regular contrast enhanced images, it's something to be concerned about. Another application is when we look at bowel contents. For example, if we're worried about a GI bleed and we see some hyperdensity in the bowel, we wonder, is this extravasation of contrast? We can again use our virtual non-contrast map to see if it stays hyperdense. If it stays hyperdense, then we know that it's not contrast and probably more likely bowel contents. And if it suppresses out, then we know that it's probably extravasation contrast, and we should be worried about an active bleed in that area. And then here's an example of how our bone marrow edema maps can help us. So especially in pelvises, I feel like our pelvic fractures can be quite subtle. So here clearly we have this deformity in the left inferior pubic ramus with an acute fracture line identified. So that's not, sorry, this is scrolling. So that's not very difficult to see, but if it will ever load again. So if we just keep scrolling through, you might say that there's no other fractures and move on, but wait, we should check our bone marrow edema maps and if it will cooperate with us. So I don't think the axials are cooperating, but if we check our coronals, we can see that that area in the inferior pubic ramus is green, so we know that that's an acute fracture. But as we scroll through, we don't see anything in the femurs. We keep looking at the rest of the pelvis. We see maybe some signal in the iliac bones, but we also see signal in the sacroiliac bilaterally, especially here. So we can go back to our traditional CT images, and we can actually see very subtle sacroiliac fractures that I would argue are very easy to walk by. I don't think we see anything much going on in the iliac bones, but that could just be bone marrow edema without obvious or without a definite fracture. But again, this is how the bone marrow edema maps can help detect subtle fractures. Sorry, the axes are not working. This is just another case of how the bone marrow edema maps might help, although we might not be able to see it. So here we can see that there's subtle fractures involving the anterior acetabulum and the inferior pubic ramus. But when we scroll through the bone marrow edema maps, it becomes much more obvious that these fractures are acute there. Not only that, we can see this old fracture on the right inferior pubic ramus is actually not edematous, so again, can help highlight acute and chronic processes. That's it for me. Are there any questions? If not, thank you for attending. We're always obviously available offline to discuss any questions, if anyone has any.
Yeah, if there's any questions about anything I covered as well, any of the protocols, any suggestions that you might have as well, please feel free to reach out anytime.
Thank you both for doing this, and thank you for lunch as well.
Yeah,
Thank
thanks
you.
for attending.
Have a good day, everyone.
Have a good one.